Hello from me. I will be discussing the First-Trimester scan. So, in every health system, there is a plan for prenatal care, which in all advanced health systems includes fetal scanning. According to EFSUMB, the International Society of Ultrasound in Obstetrics and Gynecology, the fetal ultrasound scan generally aims to provide accurate information that will facilitate the delivery of optimized antenatal care with the best possible outcomes for both mother and fetus. This, for the NHS, for example, includes two distinct fetal scans. One is suggested to be performed between 11 and 14 weeks, and the second at 18 to 21 weeks. So this is what is offered in the NHS. EFSUMB suggests that in early pregnancy, it is important, first of all, to confirm the viability of the pregnancy, then to establish accurately the gestational age, to determine the number of fetuses, and in case of twins, determine also the chorionicity and amnionicity, because that changes the follow-up of pregnancy. It is advisable to detect gross fetal abnormalities, and in case where chromosomal screening for chromosomal abnormalities is offered, to measure the nuchal translucency thickness. When should this early scan be performed? It is advisable not to offer a routine scan just to confirm the viability of the pregnancy. Not to confirm, just to confirm the viability of the pregnancy. So the first ultrasound scan in women that do not have symptoms like bleeding or pelvic pain is to be offered between 11 and 14 weeks. In all cases, it is advisable to follow the ALARA principle. That means to minimize, in terms of both time and power of ultrasound, the exposure of the fetus. Basically use the B mode and only use Doppler if it's clinically indicated. How do we define an intrauterine pregnancy? Although this seems very easy, you just see an intrauterine gestational sac and you say there it is, the criteria of a normal gestational sac are unclear in the literature. Therefore, it is advisable from EFSUMB to wait to be sure until the embryo is clearly visible in the sac. There are some clinical scenarios when you need to perform a scan early in pregnancy. For example, in cases where the woman presents with vaginal bleeding and pain. And in these cases, usually a transvaginal scan is performed. In most of the cases, you will be able to identify for sure an intrauterine pregnancy, but in some cases, the pregnancy will not be clearly visible either at the adnexa as an ectopic pregnancy or inside the uterus. In the latter scenario, you can offer serial measurements of HCG, and that would possibly guide your diagnosis. But in most of the cases, you will need to perform an extra transvaginal scan within a week, where it will be made clear if it's an intrauterine pregnancy, an ectopic, or a missed miscarriage. One has to keep in mind that an ectopic pregnancy, in most of the cases, does not present in ultrasound as a clearly visible gestational sac at the adnexa with a yolk sac inside or an embryo, more unlikely. But in most of the cases, it's either an empty sac at the adnexa or a complex pelvic mass with high vascularization. In most of the cases, it will be located at the same site as the corpus luteum. When in ultrasound we use the term viability, it is a different way than we normally use it in prenatal diagnosis. That is not to make sure that the fetus is at an age where it can survive outside the uterus, but in a different way it is used to describe a fetus that demonstrates a heart activity. We know that the fetus can be seen by ultrasound even at a length of 1 to 2 millimeters adjusted to the yolk sac, and then it increases by about 1 millimeter per day. But the cardiac activity may be seen as early as in a fetus of 2 millimeters, as in the screen, but there is a chance, about 5 to 10%, that even a longer fetus, of a longer embryo of almost 4 millimeters may not demonstrate heart activity, which will eventually be seen later. It is interesting that for a so common condition as a missed miscarriage, there is not a universally accepted definition. For example, I offer you the definitions from three Anglo-Saxon countries. In the United States, they define a missed miscarriage as an embryo which measures more than 5 millimeters by ultrasound, where you cannot see a cardiac activity. In Canada, the same diagnosis is offered when the sac is 8 millimeters and you cannot see a yolk sac, or if the sac is more than 16 millimeters without an embryo inside. On the other hand, in the United Kingdom, they state, the RCOG, that you should be uncertain regarding whether it is a missed miscarriage if the sac is less than 20 millimeters and you cannot see a yolk sac, or if the embryo measures less than 6 millimeters and it does not demonstrate a heart activity. That's why, in an interesting editorial, an opinion by the editor of Ultrasound Obstetrics and Gynecology Journal, they state that the evidence base for miscarriage diagnosis is that it's better to be late than sorry, or than never, which means that if you are in doubt regarding the clinical diagnosis, you should better repeat the scan in 7 days, and then you will be more certain about it. To determine the gestational age, one could either use early in pregnancy the measurement of the gestational sac, and that is to find the average of 3 orthogonal measurements of the gestational sac, but it is more accurate to measure the crown ramp length, or CRL. There are certain rules of how one should measure the CRL, because even 1 millimeter difference makes a difference in the estimation of gestational age so early in pregnancy. This can be performed either transabdominally or transvaginally. There should be a clear midline sagittal section of the whole embryo. The embryo should be in neutral position, not flexed or hyperextended, and it should be magnified to fill most of the screen. And on the screen, you can see 2 examples of a correct on the right-hand side and a wrong measurement of the CRL. It is important to determine the number of fetuses. The earlier the pregnancy, the more easy to see if the pregnancy is dichorionic or monochorionic. You can determine that at 12 weeks by some specific signs like the lambda sign and the T sign of the membrane separating the 2 sacs. And that is important because it alters the follow-up of the pregnancy. A monochorionic pregnancy is associated with more complications, and these pregnancies need to be scanned more often. Now, regarding the fetal anatomy, from data we have from a series from many European centers with advanced fetal scanning departments, it is obvious that fetal anomalies are very common, and they are found in about 1 in every 50 pregnancies. The sad thing is that only about 1/3 of them is detected prenatally. And of course, there is variation regarding the severity of the anomaly. In a recent meta-analysis that was published in the Gray Journal by Karim et al. In 2017, it was shown that in about 30 series that were published, that were included in the meta-analysis, the detection rate of these abnormalities was low, only 1 in 3 in low-risk groups, while it was very high, more than 50% in high-risk pregnancies, which means that if you look harder, you can find double the anomalies than if you look superficially. And they concluded that the use of a standardized anatomical protocol improves the sensitivity of the exam. Now, EFSUMB clearly states that the 18 to 22-week scan that Panos will be discussing later remains the standard of care for fetal anatomical evaluation. However, it encourages looking for abnormalities, as there are a lot of pros. For example, the early detection of many major anomalies that would offer the option of termination easier and earlier in pregnancy. And there are also, however, there are some disadvantages, as the need for more trained and experienced personnel. There is no clear result on the cost-benefit ratio, and one has to keep in mind that there are a lot of anatomical structures that are developed later than the 12-week scan, for example, the brain. There is a protocol that's suggested by EFSUMB. It is a little bit outdated, in my opinion, but I think that shortly it will be updated. And in recent research from our team here in Thessaloniki, together with Professor Sodiriades, we concluded that using this protocol suggested by EFSUMB, one can detect almost half of the abnormalities in the first trimester. But what is more important, you can see all of the ones that should be always detectable in the first trimester. So this protocol includes certain views of the fetus. You basically scan the fetus from side to side and from head to bottom. And you can see the brain, you can see the limbs, you can see the stomach, you can see the abdomen. And this way, you can find some severe abnormalities like acrania, or exomphalus, or megacystis, or sometimes even a diaphragmatic hernia, as you can see in this example. Of course, you must not forget that there are certain other features that you need to look at, for example, the placenta. In cases, for example, of severe bleeding, you can look if there is a subchorionic collection associated with the bleeding. There is a trick here that one should not be fast to diagnose placenta previa at this stage. Many placentas are very close to the cervix at this stage, but most of them migrate. And also, one should keep in mind that you should look also for gynecological conditions, for gynecological pathology, for example, a uterine septa or a bicornuate uterus, and also look for adnexal masses that might coexist. Now, in terms of screening for chromosomal abnormalities, most of the discussion and the research all these past years was around detecting Down syndrome, trisomy 21, because it was the most prevalent one. And the most important breakthrough was in 1994 when Professor Nikolaidis discovered the value of nuclear translucency, and later their team developed some rules of how to measure the nuclear translucency exactly. And then later, it was implemented in the screening procedure together with first trimester biochemistry and some other ultrasound markers like the nasal bone, the ductus venosus flow, and the tricuspid valve flow. If you do all this at 12 weeks, then you can detect more than 90% of cases of trisomy 21. However, you still have about 5% of false positives, which means that that in a country like Greece, where you have about 100,000 pregnancies per year, you need to do about 5,000 invasives to detect 180 to 190 Down syndrome fetuses. Now, a breakthrough in screening for trisomies was the introduction of cell-free DNA in maternal blood, and this led to a much higher detection rate of almost 100%, but at the same time, there was no risk associated, and the false positive rate was much less than 1%. There has been some progress regarding screening for Down syndrome, apart from the fetal DNA, in terms of a meta-analysis in 2015 that showed that the risk of miscarriage from invasive procedure is not as high as it was thought until recently. So the risk is almost 1 in 1,000 now. The other thing was that RACGH, the introduction of RACGH in genetic testing, showed that the trisomies are not the most prevalent conditions that you need to look for. There are macrodeletion duplications that are almost 1% of the population, much higher incidence than trisomy 21, and that the normal karyotype by the old method of karyotyping with a culture does not detect all these findings, you need macroarray, and that would add much more findings in theoretically normal fetuses. And very interesting research by Professor Sotiriadis was that if you were to do a fetal DNA test rather than RACGAs in all cases that had undergone RACGAs, you would miss almost half of the abnormalities. Now, another important aspect of first trimester that is not yet implemented in the first trimester guideline by EFSUMB, but it is implemented in the guideline for preeclampsia screening by the same society, is that one should also check the uterine artery in Doppler in the first trimester. This, implemented together with the maternal factors, the mean arterial pressure and the PLGF in the first trimester, can identify in a wide population more than 90% of women that would develop early preeclampsia. And if women take aspirin before 16 weeks and they are and they show a high compliance, then you can reduce an amazing 90% the incidence of preeclampsia, which is one of the most important conditions in pregnancy. Back in 2008, I was hearing that women were told by obstetricians and other doctors that you don't really need to perform the first trimester neonatal scan if you're going to have an amnio later. And I was trying to convince them for the contrary. Now this changed a bit, and now they say you don't need to perform the first trimester neonatal scan if you're going to have cell-free DNA testing. I hope that following this presentation, I helped convince you that this is not the case. The first trimester scan is important, and keeping in mind the recent advances of the low risk of invasive procedures, of the of RACGH, and of the ASPR study for aspirin, everybody should be offered in advanced health systems. Thank you very much.
Okay, thank you very much, Themis. We do have a question. And the question is, are you happy to confirm an intrauterine pregnancy once a yolk sac is visible within the gestational sac? So the translation is that do you need to see an embryo or a heartbeat, or is a yolk sac a finding that makes you sure that you have an intrauterine pregnancy?
Well, yes, personally, I would be happy, but the thing is that one needs to be sure of what it is. There is a problem in the training of people in early first trimester scanning. So, if you are in doubt, you either call somebody who is more experienced, or you give it some time. The real question is, why did you do the scan? If you did it just to confirm viability, then there is no harm waiting, because you haven't seen a heart beating yet, so there is a chance that this is going to be a miscarriage. If you have signs of an ectopic pregnancy that are disturbing, you have to keep in mind that there might be a coexisting ectopic pregnancy, so that's around 1 in 40,000, but still it is a scenario. So you just need to do all the steps needed in all cases. So you need to scan the pregnancy, the uterus thoroughly, and also check the adnexa.
So yeah, I think that the meaning of all you said, the message from all you said, is that even if you do have an intrauterine pregnancy, which a yolk sac, a proper yolk sac can prove, again you have in mind that there is a very slight chance that you have another pregnancy, so you have a heterotopic pregnancy. So you don't stop by just seeing an intrauterine pregnancy, either defined by a yolk sac or by an embryo itself.
Sorry to interrupt, especially if you have an IVF pregnancy with 2 embryos inserted, and you can only see one.
That's a very good point. Good, fantastic.